vägnar där vi har försökt få ihop ett symposium som kommer att ledas av Lars Lidgren kring vilka erfarenheter vi kan dra från de nordiska registren. Efter det här symposiet så kan de som är intresserade stanna kvar och då kommer vi i Svenska höft- och knäföreningen ha årsmöte. De som inte har anmält sig kan vi inte lova lunch, men till de andra. In English, I would like to welcome you to this symposium from the Swedish Hip and Knee Association, and I would like to leave the word to Professor Lars Lidgren.
Thank you very much, Tore Dahlén. It is my pleasure today to have lead this symposium on the improvement of knee prosthetic surgery. And we would try today to give some recommendations on the experience from the Nordic registers. We have gathered today, I think, some significant experience in the speakers. The first lecture is going to be given by Ove Furnes, who is one of the leaders of the Nordic Arthroplasty registers from Norway. And he's going to be followed by Martin Sundberg, who now is in charge of the Swedish knee register. And then Esa Jemson from Finland, who recently published his PhD work on orthopedic infections, is going to present his data. And finally, the one who is running the Swedish knee register, Otto Robertson, will talk at the end. The first title is Early Complications in Knee Arthroplasty in Norway, Room for Improvement. Welcome, Professor Furnes. And there will be no questions after each presentation. There will be at the end a gathering here where you can address questions to all of them. Please.
Yeah, thank you very much, Lars, for inviting me to this meeting. Should I press here myself? And you have given me the title Early Complications in Knee Arthroplasty in Norway, Room for Improvement, and I've added some late complications also. I think I wondered if the reason for inviting me was to tell you all that actually Sweden is better than Norway, and it seems so after our latest publication of the Nordic Arthroplasty Register Association. As you can see here, the blue revision curve is the Swedish, and Denmark and Norway is here. So definitively it seems to be higher early revisions in Norway, and also it seems like the curves are spreading. So certainly there must be some room for improvement in Norway, and I will try to analyze that and say something about what we can do. This curve has been one of my favorites the last 1.5 years. It's from a publication we had on cemented total hip replacement in ACTA last year. And this curve, it shows this dotted line is the revision rate for the average cemented total hip implant. And the Charnley implant in the early time of the registry until 1995 had poorer performance than the other cemented implants in Norway. And I think it was about at this time that the Swedes abandoned the Charnley implant. But in Norway, the company and surgeons went together, made courses on how to do the implant right. We learned from the Swedish hip registry how we should do it, and from the scientific evidence, and you can see the dramatic improvement of the results of Charnley prosthesis. And now in the last 10 years, it is better than the average cemented implants. So in a way, this tells me that the dogma of knowing your implant, knowing how to use it, and use it often, and then it will go good for you and the patient, I think is very right. And I think that can also be said for knees, and I will show some evidence for that. First, I present a study on the survival of knee prosthesis used in Norway with emphasis on patella resurfacing and also on prosthesis brands. In Norway, there has been a decrease in use of resurfacing of patella in total knee replacement and an increase of use of non-resurfaced. This is contrary to what is done in US. And it's now only under 5% which is resurfaced. One of the reasons for this is, of course, results from the Swedish registry and also from our registry. We published our first paper in ACTA in 2002, showing that there actually was no difference in revision rate, but we had a little increase in infection if you put in a patella button. There was, of course, more loosening of patella component if you put it in, but there was more revisions due to pain alone. But of course, in a registry, we don't know if the patient and function of the patient. So we have investigated that in a later paper that I will come back to. So that's one of the reasons why we did this study, to follow if the long-term consequences of using a patella button.
There are more places in the front here. There are more places here in the front. Please come on.
We used Cox regression, the endpoint for all revision, and specific reasons for revision. We adjusted for different confounders, and the reference category was prosthesis with patella component, and AGC was the comparison when we compare the brands. And the bottom line is that there is no difference in the endpoint all revisions after 15 years. But the different reasons for revision, there are more tibial loosenings if you use a patella button. One of the reasons could be that you get a higher patella offset and more torque and mechanical loading on the tibial component. That's just a hypothesis. There is also a tendency to more infections, but the later 10 years it was not shown. There is, of course, more revision due to pain alone, but most of these are when the surgeon put in a patella button. And there is more wear of the polyethylene, and that could be one of the reasons. There is more wear load of particles in a patella resurfaced joint. When it comes to the results of the prosthesis, it seems like the newer prosthesis used the last 10 years have better results than the older one. We don't know if this is a volume case or if the prostheses are poorer, but it seems to be better results for the newer implants. For the discussion of this paper, it seems to be more wear if you use a patella component, and the loose tibial component could be due to more wear particles or higher patella offset. And the question of pain, is it only that the surgeon have an option when the patient complained and you can put in a patella component? We have addressed that in the next paper. Just to show you the Genesis 1, the patella groove was very shallow, and if you malrotated the components, you would easily get higher load laterally. With the Profix, which is more anatomically profiled, it seems to me be more patella friendly. Is this something that can affect the function and pain of the patients? addressed this in this paper published this year in ACTA. Whiteside has said that you don't need a patella component if the knee is patella friendly, so we wanted to investigate if that was true. We made a patient survey to patients aged 86 years or younger with intact cemented primary total knees, only gonarthrosis, at least 2 years since surgery, and restricted the prosthesis branch to more than 100 prostheses. We used the Coos subscales and also Charnley category and also EQ5D and asked the patients of their score. We investigated the effect of resurfacing with these 4 implants that had at least over 100 with patella resurfacing, and investigated effect of brand with these implants. We did logistic regression for the confounders. So the main results is that there is no difference in outcome on Coos score and on pain on a VAS scale or satisfaction with the knees. And also within the brands, there was no difference between the brands, but the red one here is Genesis 1 with a shallow groove, and the next scan is green. There is a statistically significant better results with the next gen, but it's marginally clinical significant. So it seems like there are better results with the more patella-friendly designs, and there could also be other aspects with the new brands. So, for conclusion at these 2 papers, resurfacing of the patella has no clinical effect on pain and function, and this is supported by the large English study by Johnston and co-authors published last year in JBJS with over 2,000 patients. There was no difference in pain and function. And it seems like appropriate design of total prosthesis might have an effect on pain and function. So the next question is, does it help to have a mobile bearing? We investigated AGC, LCS, and Profix knees. The LCS has a mobile bearing, either meniscal or a rotating platform. AGC has a monoblock implant with a polyethylene molded to the metal, and the Profix is a conventional modular implant. It seems to be more aseptic loosening in the LCS knee, but it's very few. You see the scale is 99. There is definitively more tibial loosening in the LCS than in the other 2. One of the reasons could be the high flange here in the Profix knees. We don't know if it has anything to do with the mobile bearing, but in a way, mobile bearing should decrease the load on or the torque on the tibial component and decrease the tibial loosening, but with more than 10 years of follow-up, it hasn't proved to be right. Pain alone, it seems to be better with the LCS, and that has been one of the reasons why they advocate mobile bearing to get better bending and patella tracking. So might be that is right. There's no effect on the wear of the tibial insert, but they have more luxation. You have the spin-out problems with the mobile bearings. So we have also looked at the uni knees compared with the total knees. And there is a 2 times increased risk of revision in uni knees compared to total knees, and that's the same in all other register studies, and this is true for all age groups. The question is it worth giving uni knees compared to total knees? What are the functions? And so we have done a postal survey asking the question about the Coos score, and there seems to be a trend to a little bit better scores for the uni knees, knees, but it's not statistically significant, and it's not clinically statistically significant. And you might say that the uni knees are probably better off before surgery also. We have also looked into the 42 item scores of the Q score, and what we found were that there was definitively better scores on symptoms and pain, on questions of bending the knee. Then the uni knees were better, and this is in accordance with one randomized study, the only one randomized study comparing total knees and uni knees from Bristol. So there might be better bending of the knees in uni knees, and that's something you have to question you if that's worth the increased revision risk. We have also looked into the short-term results of computer-navigated total knees. It was presented at the NOF meeting this year, and we have nearly 1,500 computer-navigated knee in Norway. In 2009, it was 20% of all the total knees. So we were very eager to see the short-term results of that, and here is the answer. It has been a disappointment, and as you said nearly 20 years ago, is this one step forward and two steps back? There are more revisions in the computer-navigated group. The one-year revisions, there is very little difference, but at 2 years it's significant, and it's nearly 2 times more. So this is at a cost of nearly 6,000 Norwegian kroner, or $1,000 per patient, and it gives you 2 times more revision, and it also gives you much more operating time. In the CAS group, 107 minutes. In the conventional group, 92 minutes. So I think this has been a disappointment. We have also looked at the yearly hospital volume of surgery in cemented primary knees, and it seems like you get better results if you have at least more than 100 implants per hospital. Regrettably, we don't have registered the surgeon and the surgeon volume, but we have just sent out a questionnaire asking how many they operate, and this is one of the curves from that survey. It seems like if the proportion of consulting surgeon doing less than 10 total knees per year, if that's lower than 1/3 of the surgeons in the hospital, you get a better survival. We have also looked at what happens if you have a tender in a health region. In Norway, there is 4 health regions and nearly 1 million people in each health region, and they decided to have only one prosthesis in this health region, and the curve is from 2004 to 2006, the green, and then they demanded all the surgeons to change to a new implant that was cheaper, and you see the early complications here. So that's something you need to be aware of. This is some new CE rules, and the administrator think they can then save money. And then a curve from Otto's paper, the NARA paper, showing the incidence of knee replacement in Norway, Sweden, and Denmark. The blue curve is Sweden. You see that you had a higher incidence here in the mid-90s. There was 50 per 100,000, but in Norway it was 30. The black one here is Norway, and Denmark is the red one. The confidence, the red one. The confidence lines is dotted here. So you see that it seems like we are lacking behind here, and it could be that some of our poorer somewhat poorer results in Norway could be because of this surgeon volume and learning
one
curve.
minute.
We have also looked at the risk for revisions in knees, and in total hips it seems to have been more infections lately, but for knees it's less infection than in the first period. This could be a learning curve situation, but as you see, the number of revisions in hips and knees are now the same in the last 10 years in Norway. The new bone cements used the last 5 years, there is no difference in the new bone cements. And I also want to stress that in the early phase, pain and infection is the problem in revision. There has been an improvement over the years for total knees, but not for uni knees. And to the conclusion, there has been an improvement of results in total knee replacement in Norway, possibly due to improved surgical skill and better implants over time. We don't need to use patellar resurfacing. Computer navigation seems to be one step back. No benefit of using mobile bearing implants regarding tibial loosening. Pain and infection is the main early reasons for revision and needs to be reduced, and we need to focus on that. And there seems still to be room for improvement to come up to Swedish level, possibly linked to better surgical skill and volume, selection of patients, and improvement of implants and technique. Thank you.
Thank you very much.